So we'll be discussing about management of ARDS part 2, which includes the ventilatory and the non-ventilatory management and related evidences. So as I told you, we'll be discussing about ventilatory and non-ventilatory management and also supportive management in ARDS. So this flow chart gives us a gist of what we are going to discuss today, that the management of ARDS includes ventilator management and the other rescue therapies. Along with that, there are also general measures like nutritional support, prevention of stress ulcers and thromboembolism, and re-evaluation of the ventilatory parameters at least every 24 hours, and other pharmacological therapies. Coming on to the non-ventilatory management. Whenever there is an hypoxic patient who is spontaneously breathing, there will be increased respiratory drive because of hypoxia, lung edema, reduced lung compliance, inflammation, and agitation. This will lead to increase in the inspiratory effort and increase in the transpulmonary pressure swings, leading to increase in tidal volume and increase in the respiratory rate. At the same time, because of the lung inhomogeneity, because of the gravitational forces and regional inflammation, there will be solid-like behavior, and there will be dorsal collapse. There will be increase in the dorsal transpulmonary pressure shifts. Overall, this will lead to occult pendle lift, where there is ventral to dorsal shift of the gas at the beginning of inspiration, leading to increased dorsal tidal volume, ultimately leading to the patient-inflicted lung injury, causing volutrauma, barotrauma, and atelectotrauma. How does the non-invasive ventilation help here? Here, the non-invasive ventilation reduces the risks of VAP by reducing sedation, being on a ventilator, and by improving the diaphragmatic function, and also changes with the heart lung interaction and the cardiac support. So, in an ARDS patient who are spontaneously breathing, if suppose the patient is hemodynamically unstable, there is multi organ dysfunction, there is altered sensorium, PF ratio is less than 150, there is severe respiratory distress, you go ahead and tube the patient. But if the patient fits into mild to moderate category, then you try for high flow nasal cannula for 1 hour. If that fails, intubate. But if there is no improvement in the PaO2 and the patient still PF ratio is around less than 300 with mild hypoxia, then you can try NIV for 1 hour. If that fails, again intubation. If not failing, then continue NIV. But if the patient is having a PF ratio of more than 300 millimeter mercury, then you continue with the standard oxygen therapy. So coming on to some of the evidences for NIV and high flow nasal cannula, I have taken the recent important ones only, where there was a large observational study to understand the global impact of severe acute respiratory failure, which is called a lung safe trial, which was one of the large observational trial for ARDS globally, had found that the NIV was used in 15% of the ARDS cases. And the failure rates varied with severity, meaning mild ARDS had a failure rate of 22%, where severe ARDS had a failure rate of 47%. So the ICU mortality was higher in patients with NIV failure, that is approximately 42.7% compared to the other intubated patients. And the PF ratio, when it was less than 150, NIV resulted in a higher ICU mortality than the invasive mechanical ventilation. So what is the ultimate draw point here? Whenever the patient is having mild to moderate ARDS and hypoxic respiratory failure, then you can try high flow nasal cannula or NIV. But when they are fitting into moderate to severe and clinically unwell, then you have to go ahead and tube, because the NIV could increase the mortality rates. Coming on to high flow nasal cannula, there was one meta-analysis by ATS in 2019, where they utilized data from all the randomized control trials, like including Florari trials and other trials, where they included ARDS patients stratified by severity and treated with high flow nasal cannula or NIV, with outcome measures such as intubation and mortality rates, where they found that high flow nasal cannula showed lower ICU and 90-day mortality compared to standard oxygen or NIV in moderate to severe ARDS also. And the NIV failure rates remain high in the hypoxemic respiratory failure, especially in the severe cases. So the outcome is the high flow nasal cannula reduces the intubation and mortality in hypoxic respiratory failure patient. When it comes to NIV, when we use it with helmet, can decrease the intubation compared to the standard marks. And ROX index is the one which helps in assessing the failure rates for high flow nasal cannula. Okay, so as I told you, this is one of the named trial called Florari trial conducted by Frat et al., where they used high flow nasal cannula in hypoxic respiratory failure, where they found that treatment with high flow nasal cannula did not produce significantly different intubation rates, but however, the 90-day mortality rate showed a substantial difference in favor of high flow nasal cannula. Okay, so this is a gist of all the trials for NIV and iFlow, a study conducted by Duane et al. In 2017, where they applied NIV through a full face mask with a PEEP of 4 to 8 centimeters of water, and the inspiratory pressures were set at 10 and increased stepwise by 2 centimeters of water. And whenever a HACOR score of more than 5 point predicted the NIV failure, and there is lower hospital mortality if invasive ventilation commenced within 12 hours of NIV failure with a HACR of more than 5 at 1 hour of NIV commencement. Okay. And then came the Florali in 2015, where NIV was given through face mask or iFlow was compared, and standard oxygen therapy was compared as a control group. 28-day intubation rates were similar in all the groups, but in the mortality rates were better with iFlow group. Okay. And there was one more study conducted by Patel et al. In 2016, where ARDS patients requiring mask for at least 8 hours were included in the study, and helmet NIV versus NIV through mask was compared. There was lower intubation rate with helmet NIV and more ventilatory free days with helmet NIV, and 90-day mortality rate was lower with helmet NIV. And then came Franco et al. In 2020, where they included COVID-19 patients, where NIV support out of ICU with high flow nasal cannula, NIV with CPAP alone, or NIPPV, where they found similar intubation rates and 30-day mortality with all three modalities. Study showed feasibility of NIV support outside the ICU also. So this table is very important because recently they are picking up scores from a small just table and they are asking it as a 3 mark or a 5 mark, where this is a table showing what are all the physiological measures you should use for monitoring when you use high flow cannula or NIV, where SpO2, FaO2 index can be used as a hypoxemia index, where the clinical threshold is less than 120 and worsening trend indicates severe hypoxemia. And then you can use PF ratio using ABG, where if it is less than 150 to 200 and worsening trend indicates severe hypoxemia. And respiratory rate can also be used as a part of clinical examination. When it is more than 25 to 30, it indicates severe disease. And expired tidal volume from the ventilator can be used. When it is more than or equal to 9 to 9.5 ml per kg of predicted body weight, indicates failure. And even esophageal manometry can be used to monitor the hypoxemic patients, where if the delta PES is around more than 15 centimeters of water or reduction less than 10 centimeters of water during NIV, then it is indicating failure. Then comes the ROX index, which is nothing but SpO2 by FaO2 divided by respiratory rate. If it is less than 2.85 at 2 hours of high flow, or less than 3.47 at 6 hours of high flow, or less than 3.85 at 12 hours of high flow, indicates failure. And Hacker scale, which includes heart rate, acidosis, consciousness, oxygenation, and respiratory rate. If it is more than 5 at 1 hour of NIV initiation, indicates it's a failure. So this is a picture depicting the various masks we discussed now. The high flow nasal cannula, where the settings available are FaO2 between 0.21 to 1, and the gas flow can be adjusted between 40 to 60 liters per minute, and temperature is humidified between 31 to 37 degree Celsius. Benefits: it matches the inspiratory flow, delivers set FaO2, delivers fully conditioned gas, it enhances the comfort, provides positive airway pressure up to 4 centimeters of water, washout of the nasopharyngeal dead space, and it reduces the inspiratory effort. But the pitfalls: small amount of PEEP is only delivered, approximately 4 to 5 centimeters of water. Coming on to face mask in NIV, uh, the pressure support ventilation requires ventilator, where you can titrate the FaO2, PEEP, and pressure support. FaO2 can be titrated between 0.21 to 1. PEEP can be adjusted between 5 to 8 centimeters of water, and pressure support can be adjusted between 7 to 10 centimeters of water. If you are using a CPAP mode, then continuous flow more than 30 liters per minute can be set, or CPAP mode on the ventilator can be tried, and PEEP can be set between 5 to 8 centimeters of water. Use of HME is advisable. Benefits: again, you are setting the FaO2, it again delivers fully conditioned gas, it provides PEEP to allow the alveolar recruitment, and it also provides pressure support to unload the inspiratory muscles. It allows to monitor the tidal volume in pressure support mode. Only thing is patient can develop skin ulcers, air leaks can be there, difficult delivery of high PEEP. Full inspiratory synchronization may increase the transpulmonary pressure swings and tidal volume, and poor tolerability, need for treatment interruptions may be there. Coming on to helmet and IV, where again the pressure support and the CPAP adjustments can be done. Where benefits, it again delivers a set FiO2, provides higher PEEP to allow the alveolar recruitment and enhance the ventilator homogeneity. Continuous treatments with good tolerability. It provides pressure support, and asynchronous pressure support may prevent positive transpulmonary swings. But pitfalls are impossibility to measure the tidal volume. Upper limb edema can be there with possible vessel thrombosis. So this is a chart depicting how the flow of the oxygen would be in different modes. Where you can see in standard oxygen therapy, it delivers a consistent low flow of oxygen without significant changes in the airway pressure. So there is minimal influence on the airway pressure, transpulmonary pressure as depicted by the flat tracings, showing no added pressure support or inspiratory flow dynamics. But when you come to high flow nasal cannula, at a flow rate of 60 liters per minute, high flow nasal cannula provides a mild continuous positive pressure of 3 centimeters of water, reflected in the steady elevation of the P airway pressure. And the high inspiratory flow aligns with the patient effort, reducing the esophageal pressure fluctuations and inspiratory effort. So it improves oxygenation while maintaining a low but consistent pressure in the airways, as shown by the stable PL. Coming on to CPAP, it maintains a fixed pressure at 12 centimeters of water throughout the respiratory cycle, as indicated by the consistent airway pressure tracing. This reduces the esophageal pressure swings and stabilizes the transpulmonary pressure, supporting alveolar recruitment and oxygenation. And then comes the NIV, where it combines PEEP and the pressure support. And NIV shows intermittent high airway pressures during inspiration corresponding to the pressure support delivery and generates larger transpulmonary swings compared to the CPAP. This leads to higher tidal volume and improved ventilation, but requires careful monitoring because patient-inflicted lung injury because of the increase in the transpulmonary swings. Coming on to ventilatory management of ARDS, where it can be divided into standard of care and rescue strategies, where standard of care includes low tidal volume, optimal PEEP, managing the P plat and the diving pressures, and transpulmonary pressure adjustments, and mechanical power. And the rescue strategies include prone positioning, recruitment maneuvers, neuromuscular blockers, inhaled vasodilators, and ECMO. We'll see everything in detail. So, this picture illustrates the evolution of the ventilatory strategies in critical care from 1970s till the 2020s, reflecting a shift in focus from the oxygenation to lung protection. Okay, so in the early 1970s, the attention was given to oxygenation mechanics and hemodynamics, which evolved in 1980s to distinct focuses on oxygenation and hemodynamics. By 1990, the pressure volume curve was introduced to optimize ventilation. The 2000s marked the adoption of the open lung strategy, including the PEEP tables and the stress index to improve the recruitment and prevent overdistension. In 2010s, the focus shifted to recruitability, emphasizing the limitation of plateau and the driving pressures, alongside the imaging techniques such as CT scans. By 2020s, the advancement targeted changes in gas volume using tools like double PV curve and recruitment ratios, with further reliance on imaging modalities such as CT, lung ultrasound, and electrical impedance tomography. Overall, the trajectory highlights a move towards a lung protective strategy rather than just blindly improving the oxygenation and the hemodynamics. Coming on to the lung protective ventilation. What is a baby lung? So, ARDS as normal lung and unaerated and partially aerated alveoli, right? So the normal segments inflate easily, but unaerated segments, they distend poorly when you give a positive pressure. So these unaerated segments do have a higher pressure and a slow response pattern. And the normal lung segments may be overinflated when ventilated with the traditional lung volumes. The baby lung is getting affected as a collateral damage when you ventilate the patient with an ARDS. Okay, so what are all the various types of valley we do see? Strain, which is due to the over distension of the compliant alveoli leading to volutrauma, or there could be high inspiratory pressures leading to barotrauma, and there could be shear stress due to the complete closure and reopening of the non-compliant alveoli leading to atelectotrauma, And the release of inflammatory mediators from the lung could be named as biotrauma. And there is also something called ergotrauma because of the mechanical power. Okay, this we discussed with the effects of positive pressure ventilation on the lung. That is why I didn't go in detail. Let us just see the lung protective ventilation, that is with low tidal volume. Okay, the low tidal volume ventilation improves mortality significantly in an ARDS patient. That is why the low tidal volume is the cornerstone of the ARDS management. Here, neither mode is superior. Whether it's a pressure control or a volume control, none of the mode is superior. Okay. And the low tidal volume ventilation overall reduces the driving pressure, the mechanical power, and the risk of the volume on an ARDS lung. And the low tidal volume, that is 4 to 6 ml per kg, may still result in barotrauma in a poorly compliant lung. Okay, this barotrauma might be mitigated by further reducing the tidal volumes in a volume control mode or in a pressure control mode. The lower tidal volume may also be poorly tolerated in some of the patients, leading to increase in the ventilator asynchrony and the requirement of deeper sedation. So there are landmark trials when it comes to lung protective ventilation with low tidal volume. The one in 2000, which is also called as ARMA trial or ARDS net study, where it was a randomized control trial involving around 861 patients, where they demonstrated that a tidal volume of 6 ml per kg ideal body weight when compared with 12 ml per kg ideal body weight reduced the mortality and increased the ventilator free days. Where the tidal volume ranged between 4 to 8 ml per kg in the trial, the goal tidal volume used in the protocol was around 4 to 6 ml per kg, depending on the plateau pressure changes. And the mean plateau pressures were maintained between 25 to 33 centimeters of water. Okay. And there was a meta-analysis recently released involving 6 randomized control trials comparing ventilation strategies using tidal volume of 7 ml per kg or less versus ventilation that used tidal volume between 10 to 15 ml per kg, where 1,297 patients with ARDS were included in the meta-analysis. So the 28-day mortality was significantly lower in a low tidal volume group compared to the high tidal volume group. And the mortality rate in the control group was not significantly different if a plateau pressure of 31 centimeters of water or less was maintained, which is indicating the importance of maintaining the plateau pressure less than 30 centimeters of water. So low tidal volume, it is always often encountered with hypercapnia resulting from low minute ventilation. So there is a strategy called permissive hypercapnia, where you are permitting a higher than normal level of arterial carbon dioxide so that the lung protective ventilation can be continued. There is no defined safer limit of carbon dioxide or a pH target has been indicated in the studies, but experts suggest that continuing the lung protective ventilation and treating metabolic acidosis with soda bicarbonate when the pH level is below 7.2. Okay, and we can also use ECOR therapy to maintain low tidal volume or reduce the tidal volume to even ultra lower levels to 3 ml per kg of predicted body weight for ultra protective lung ventilation. Okay, so the recommended tidal volume is 4 to 8 ml per kg of predicted body weight to target a plateau pressure of less than 30 centimeters of water in all ARDS patients. Coming on to optimal PEEP, which was initially defined as open lung ventilation, where the positive end expiratory pressure opens the collapsed alveoli, allowing for recruited lung to participate in the gas exchange, and they reduce the alveolar overdistension by increasing the distribution of the tidal bed. Okay, in ARDS patient, there is heterogeneity. So different phenotypes may respond differently to PEEP. So with studies, there is no clear mortality benefit in ARDS when compared with high PEEP versus low PEEP strategies in a patient with low tidal volume ventilation. But however, there may be benefit with oxygenation index when it is used in moderate to severe ARDS patients. Okay, so lung recruitability when you apply PEEP can be defined as the proportion of the lung tissue in which aeration is restored at increased airway pressures. Okay, whenever you give a PEEP, the end expiratory lung volume is definitely increased regardless of the recruitment. Yeah, and the changes in the end expiratory lung volume induced by the PEEP can be divided into recruited volume, that is the volume recruiting the new lung regions, or hyperinflating volume, where the volume over distending the already open baby lung, which is detected by the recruitment to inflation ratio. Okay, in patients with low recruitability, PEEP can result in over distension, strain, and lung injury. And the recruitment to inflation ratio equal or higher than 0.5 corresponds to high lung recruitability. This recruitment to inflation ratio can be calculated by performing a single breath decremental PEEP by 10 centimeters of water. So it is calculated as the compliance of the recruited lung divided by compliance at the low PEEP. It may help to identify high or low recruiters at the bedside. So, what are all the problems with the PEEP? On the positive way, it could cause alveolar recruitment, decrease in the dynamic lung strain. There could be decrease in the pulmonary vascular resistance, decrease in the left ventricular afterload, and it reduces the shunt. It doesn't ventilation distribution. But what is on the negative side? It can cause alveolar overdistension. It can cause increase in the static lung strain. There could be increase in the mechanical power, electrotrauma, volutrauma. There could be increase in the pulmonary vascular resistance, decreased left ventricular filling, decreased venous return, decreased planktonic blood flow, and sodium and fluid retention. So, what are all the methods available to titrate the PEEP? Number one, you can arbitrarily use in high PEEP set to 15 to 20 centimeters of water. Okay, or you can use ARDS net PEEP or FAO2 escalation tables. Then you can titrate the PEEP according to maximum compliance, meaning set the PEEP which achieves the highest static compliance. Okay, and then you can set the PEEP to slightly above the lower inflection point of the pressure volume curve. You can also use a staircase recruitment phenomenon to find the lowest PEEP at which the maximal oxygenation is maintained. You can also titrate PEEP to achieve the smallest intrapulmonary shunt using a PA catheter with continuous SVO2 monitor. You can also titrate the PEEP to achieve the lowest arterial minus end tidal CO2 gradient. You can also use transpulmonary pressure calculated from the esophageal balloon manometry using the esophageal pressure as a surrogate marker for pleural pressure. Adjust the PEEP so that the transpulmonary pressure at end expiration is between 0 to 10. You can also use electrical impedance tomography to titrate the PEEP to achieve the highest electrical impedance in the thorax. You can also use sequential CT scans to visually determine a PEEP at which greatest volume of lung is recruited during end expiration. So some of the advanced methods for individualized PEEP titration. Number one is the stress index, which can be detected from the pressure time curve or the flow time curve, where when measuring the stress index, the flow must be constant. Okay, as when the flow is constant, the volume and the time become the linear analogs. So the flow must be constant so that the deformations of the pressure curve reflects the alterations in the elastic properties of the lung rather than demonstrating the changes in the flow. So whenever the stress index is more than 1, achieve a reduction in the PEEP. Then comes electrical impedance tomography, which we'll see in the next slide, and esophageal manometry are some of the methods which can be used to titrate PEEP. So what is electrical impedance tomography? This was asked as one of the short notes in the previous papers. It is a non-invasive radiation-free bedside imaging tool used for monitoring the lung function. It allows the continuous and real-time evaluation of the ventilation and perfusion, optimizing the mechanical ventilation settings. So it can detect the ventilation heterogeneity, regional lung collapse, over-distension, or a pneumothorax. It also identifies complications such as de-recruitment during procedures like suctioning and monitors ventilator descent crannies such as pendulant or breath stacking. Okay, so it has potential clinical application to reduce the villi and improve the outcome in severe ARDS patient. So this is how it has been done. So the placement of the electrode belt on the chest, approximately between the fifth or sixth intercostal space, and the computed tomographic axial slice of the thorax with 32 electrode belt and schematic representation of the electrical current pathways through the thorax. So one part of the electrodes inject the electrical current, while the remaining electrodes read the voltages produced as a result of the distribution of the current density inside the thorax. So the injection pair is alternated sequentially, and after a full cycle of one image will be generated. So the functional image reconstructed by electrical impedance tomography using a color scale has been seen in the image C, where lighter the blue, the greater is the regional ventilation. So these are some of the trials for open lung ventilation, where alveoli trial in 2004, Laos trial in 2008, Express trial in 2008, Kakmarek in 2016, all showed there is no improvement in mortality, but there could be improvement in the oxygenation. And there is also a trial called EP-VEN trial in 2019, where they used esophageal manometry to adjust the PEEP, where they found that less rescue therapy at 28 days, but no difference in mortality or ventilator-free days. Coming on to driving pressure, it is nothing but plateau pressure minus P, which correlates the global lung strain. It is the ratio between the tidal volume and the respiratory system complaints. So basically, it gives us the volumetric information plus information of the lung strain, overall the global lung strain. So this was one of the study conducted by Amato et al., which is conducted as a mediation analysis involving 3,652 patients with ARDS across 9 randomized controlled trial to determine the optimal ventilatory settings for improved survival, where they used driving pressure, tidal volume, PEEP, and plateau pressure as a predictor of mortality at 60 days. The driving pressure emerged as the strongest independent variable associated with the survival. So higher the driving pressure predicted increased mortality, particularly when higher driving pressure was increased with elevated plateau pressures also. So the authors concluded that the driving pressure acts as a surrogate for cyclic lung strain, with a driving pressure of less than 15 being the most reliable threshold for stratifying patient risk and improving the survival outcomes in ARDS. Coming on to transpulmonary pressure. The transpulmonary pressure is the pressure difference between the airway opening and the pleural space. So it comprises the pressure to move the air through the lung and the pressure to overcome the lung tissue elastic recoil. Okay, so the physical quantity measuring the mechanical load applied to the lung during ventilation. It provides more accurate measurement of lung stress and risk of injury. So the transpulmonary pressure is usually assessed at two critical points during the breathing cycle. At the end of inspiration, which is relevant to prevent hyperinflation. At the end of expiration, which is relevant to avoid lung debris recruitment. So if the respiratory flows are zero at these points, the airway pressures are presumed to represent the alveolar pressures, a reasonable assumption in the absence of gas trapping. So how we can measure the transpulmonary pressure? Esophageal manometry is used, which is a special balloon, either incorporated in a standalone catheter or as a part of NG tube, is positioned with a specific protocol in the lower third of the esophagus and connected to a pressure transducer. And correct balloon position is confirmed by the presence of cardiac oscillation in the esophageal pressure tracing and the measurement of the airway opening and the esophageal pressure swings with occluded airway opening. So what are all the methods of measurement of TPP? Method 1, where measurements can be made at the end inspiration, where transpulmonary pressure is equal to P plat minus esophageal pressure at end inspiration, and end expiration, where the transpulmonary pressure is equal to P minus esophageal pressure at end expiration, which can be affected by the weight of the mediastinum and abdominal pressure and esophageal balloon positioning. Okay. There is a method 2, where there is a compliance derived strategy and release derived strategy. Where in compliance derived strategy, the product of the plateau pressure and the ratio of the compliances of the respiratory system and lung has been included. And in release derived strategy, changes in the airway and the esophageal pressure from the atmospheric pressure due to tidal inflation and PEEP is being included. So it involves opening of the ventilatory circuit to atmosphere with the risk of lung derecruitment and hypoxemia. So this method assumes that in each patient that the changes in esophageal and airway pressures are linear during tidal volume inflation and PEEP changes. Then comes method 3, where PEEP step maneuver and measurement of changes in the end expiratory lung volumes using the spirometer, which could be available in some of the ventilators. So this is an image illustrating the measurement and the interpretation of the esophageal pressure to estimate the pleural pressure and the transpulmonary pressure in a mechanically ventilated patient, where panel A shows that the setup involving the esophageal balloon catheter placed in the lower third of the esophagus, which is used to measure the esophageal pressure as a surrogate marker for pleural pressure. Gentle chest compression and airway occlusion maneuvers help validate the balloon positioning, and the graph below demonstrates the airway pressure with the blue line and esophageal pressure with the green line and the transpulmonary pressure with the red line during expiratory hold and chest compressions. So how do we approach with driving pressure and transpulmonary pressure? First, you set up the low tidal volume, you monitor the driving pressure. If it is more than 14 to 18 centimeters of water with high risk conditions, then consider inserting the esophageal balloon and monitor the transpulmonary pressure. If no, you look at the plateau pressure. If it is more than 30, then again try inserting the esophageal balloon catheter and monitor the transpulmonary pressure. If not, then try to reduce the driving pressure by optimizing the PEEP, by recruiting the lung, and also by adjusting the tidal volume to 5 to 6 ml per kg of the predicted body weight. Coming on to the rescue strategies. First rescue strategy we are going to look at is recruitment, which is a dynamic process of opening the previous to collapsed lung units by increasing the transpulmonary pressure. It is mainly aimed at to improve the oxygenation and the lung compliance. So if you do intentional transient periodic application of higher pressure maneuvers, then there will be maintenance of patency of the alveoli, but it has higher risks of villi and higher mortality. So in the picture, you can see the recruitment maneuver can do anatomical recruitment as well as functional recruitment. So the recruitment maneuvers can be of various types. One is sigh, sustained inflation, extended sigh, prone ventilation. So the methods are 40 centimeters of water for 30 seconds, increase the peak to 40 centimeters of water for 40 seconds, 3 consecutive sighs per minute with a plateau pressure of 45 centimeters of water, 2 minutes of peak pressure of 50 centimeters of water and PEEP above upper inflection point, slow increase in the inspiratory pressure up to 40 centimeters of water, stepped increase in the pressure. So it's also called staircase recruitment menu. So coming on to physiology of RM, it provides a static or dynamic inflation at very high pressure for a shorter period of time to recruit the alveolar units to participate in the gas exchange and improve the respiratory system compliance. And most lung recruitment occurs in the first 10 seconds of sustained inflation, while hemodynamic instability occurs after the 10 seconds. The effects of increasing PEEP likely stabilize after 11 to 20 breaths. It improves the oxygenation, but has never been shown to improve mortality. It can also be injurious. So there are some of the trials like ART trial in 2017 and Farlap trial in 2019 used this open lung ventilation maneuvers, recruitment maneuvers in ARDS patient where there was no improvement in the mortality. So this is a table showing the use of recruitment maneuvers in various studies. There was improvement in the oxygenation. There was no mortality benefit. Coming on to prone ventilation. We all know that the prone ventilation improves the oxygenation and the ventilatory mechanics, and it is mainly indicated during moderate to severe ARDS after appropriate ventilator optimization. So it improves the heterogeneity, allowing for increased lung recruitment, ventilation perfusion matching, and decreased overdistension and lung stress. Okay, the one important trial when it comes to proning is the PROSEVA trial, which is the notable study for yearly proning in patients with moderate to severe ARDS. And the 28-day mortality in the proning group was 16% compared to 32% in the supine group. And the 90-day mortality in the proning group was only 23% compared to 41% in the supine group. So the average duration per proning session in this study was around 17 hours, and each patient underwent 4 proning sessions on average. So the lung collapse in ARDS happens because of 3 reasons. Number one, edema, where edema has a non-gravitational distribution, unlike in cardiac, which has a gravitational distribution and is homogeneously distributed throughout the lung parenchyma. The second reason is the superimposed pressure, that is the heart weight. Increase in the lung mass in ARDS patient due to edema and the increased superimposed pressure from the heart, where the heart weight squeezes the gas out of the gravity-dependent lung regions, leading to loss of lung aeration. And then comes the third reason, that is the shape matching, where the fitting of the elastic cone into the rigid cylinder is difficult in an ARDS lung. So the first one is the sponge theory, where if the sponge is removed from the water and held flat, the water drains from it and then it slows to a stop, right? But when you turn the sponge from horizontal to vertical position, again the drainage begins and then again it slows down to stop. As it slows down, the sponge is not equally wet from top to bottom, the top having more empty pores than the bottom. There's a sponge lung in ARDS patient where edema increases the lung weight and squeezes the gas out of the dependent lung region, producing alveolar collapse and increasing the densities in the dependent region, causing compression atelectasis. Coming on to the second theory, that is the shape matching. So we know that the lung is a conical shaped structure, with the dependent side being the bigger than the non-dependent side in the supine position. And the chest wall is a cylindrical shaped structure. Because the two structures have the same volume, the lung must expand its upper regions more than the lower ones, and this results to a greater expansion of the non-dependent alveolar units, or otherwise to a lesser expansion of the dependent units. So what happens in supine position? The gravitational forces, the increased superimposed pressure, and the shape matching of the lung into the chest cavity act to the same direction, having a detrimental effect on the dependent alveolar units. And in prone position, this shape matching counterbalances the gravity and the superimposed pressure. More homogeneous inflation of the dependent lung areas happen. It also eliminates the compression of the lung by heart and relieves the dependent lung area from the abdominal pressure. Here, the shunt lessens and the oxygenation improves because of the recruitment of the dorsal areas, which overcomes the de-recruitment of the ventral regions due to shape matching. In ARDS, there is inherent non-uniform alveolar stress that is not gravitationally determined. So application of the prone positioning diminishes the alveolar hyperinflation and protects the lung from high shearing forces and eventually from bleeding. So this is the picture showing the thorax lung shape mismatch. Transverse section of the thorax has been shown and the lung is represented as the orange triangle, but the pleural cavity is represented as the yellow oval. Okay, the isolated lung in the absence of the gravity can be thought as a triangle with all the alveolar units of the same size. When the lung is placed into the thoracic cavity, the apex of the cone stretches to adapt the oval shape of the pleural cavity, which leads to an increase in the size of the units in this area. But when gravity is added, the units of the lower part of the lung tend to collapse due to the superimposed pressures of the units above. So when the patient is pronated, the hydrostatic pressure effect and the shape mismatch acts in the opposite direction, leading to more homogeneous distribution of ventilation. Again, this is the relationship between the gravity superimposed pressure and shape matching in supine and prone position. Whereas in supine position, all three act in the same direction, causing detrimental effect. Whereas in prone position, this is balanced. So coming on to evidence of prone in ARDS, where this table shows mostly the meta-analysis included. We already discussed about the ProSaver trial, and other trials are Sud et al., Lee et al., Tonelli et al., Park et al., Bloomfield et al. Showed that prone position reduces the mortality in patients with severe hypoxemia. Coming on to other rescue strategies, number one is the glucocorticoids, where we had discussed this glucocorticoids when we discussed the steroid use in ICU. The administration of empiric steroids for severe ARDS has always remained controversial. While empiric use of glucocorticoids remains controversial in all patients with severe ARDS, there are likely selected ARDS groups like inflammatory groups or in COVID-19 groups, as in Dexta ARDS trial, can be benefited with glucocorticoids. Okay. Then comes the mechanical power, where it is the mechanical energy delivered from the ventilator to the respiratory system and has been hypothesized as a unifying driver of bleeding. Patients with severe ARDS receive mechanical ventilation with higher mechanical power than mild to moderate ARDS, and it is given by the formula 0.098 into tidal volume into respiratory rate into P peak with driving pressure. Okay, so the higher the mechanical power was independently associated with higher ICU hospital 30-day mortality and decreased ventilator free days, even in patients who are receiving lung protective ventilation as per the studies. Coming on to fluid, acute lung injury during ARDS may be exacerbated by fluid overload. There was a landmark trial called FACT trial where they compared two fluid management strategies like conservative and liberal, but there was no effect on mortality. Patients who were treated with conservative fluid strategy had less fluid accumulation and increased ventilator free and ICU free days. Coming on to inhaled vasodilators, which could be in the form of nitric oxide or prostaglandins, where they improve oxygenation in the pre-F ratio by improving the ventilation perfusion matching, but they do not improve the mortality. Coming on to airway pressure release ventilation, it is an alternative mode of mechanical ventilation used to treat refractory hypoxemia in ARDS patients, where it is a pressure limited mode that cycles between two levels of CPAP. A higher airway pressure P high is set for certain time, and a lower airway pressure is set for a shorter time. and it utilizes the inverted inspiration expiration ratio, as the majority of the spontaneous breathing occurs during T high, with the P high allowing recruitment of the alveoli and T low allowing the ventilation and the exhalation. The benefits include it can be used in spontaneously breathing patients, decreased work of breathing, less dysynchrony, and lesser sedative use. So, meta analysis show improved oxygenation, but there is no mortality benefit. Further studies are needed. Then comes high frequency oscillatory ventilation, where it is an invasive mode of ventilation that employs constant airway pressure with oscillations at extremely high frequencies, delivering tidal volumes below the anatomical dead space. So the gas exchange occurs through convection and diffusion, where it was previously considered as a risky mode, but it has been declined because they had increased the mortality in patients with ARDS. The meta-analysis indicates it could still be used for mortality benefit in severe ARDS, but may worsen the outcomes in mild to moderate ARDS, and current guidelines is against its use. Coming on to neuromuscular blocker, the neuromuscular blocker improves oxygenation via several mechanisms, where the paralysis decreases the oxygen consumption, eliminates the ventilator dysynchrony, and improves the thoracopulmonary compliance. But when we use neuromuscular blocker on a longer term, the risk of neuromuscular weakness and muscle loss, pressure injuries, DVT, and requirement of the deep sedation, and increased incidence of delirium and neurocognitive impairment could be there. So there were two landmark trials called Accurasis trial and Rose trial. The Accurasis trial was conducted in 2010, where it demonstrated a mortality benefit of 48 hours of neuromuscular blocker versus satracurium in patients with moderate to severe ARDS. And then came the Rose trial, the larger multicentral trial in 2019, but they did not find any significant mortality benefit using neuromuscular blocker in moderate to severe ARDS. Coming on to ECMO, where veno-venous ECMO provides extracorporeal gas exchange in patients with refractory respiratory failure. Optimal PEEP during ECMO is typically 10 to 15 centimeters of water to balance the compliance and over distension. As per studies, ECMO had a 10% mortality benefit in selected ARDS patient. So when to consider ECMO in severe ARDS patient? When the PF ratio is less than 50 for more than 3 hours, and the PF ratio is less than 80 for more than 6 hours, or arterial pH is less than 7.25 with hypercapnia and tachypnea, and ventilator setting adjusted to maintain a PLEEP of less than 32 centimeters of water. So the initial ventilator settings in VV ECMO would be either a pressure control or a assist control, or a volume control or an assist control mode, where you select a PEEP between 10 to 15 centimeters of water in both the modes. And in pressure mode, the driving pressure target is between 10 to 12 centimeters of water, respiratory rate to be set at 10, and FaO2 less than or equal to 50%. And volume control mode, you keep the tidal volume at less than or equal to 4 ml per kg, P-plat target of less than or equal to 25 centimeters of water, driving pressure again less than 15, and respiratory rate of 10. And keep monitoring the RV function, reconfiguration to VAV ECMO or RVAD ECMO, or adding pulmonary vasodilators if there is RV failure. So there were two landmark trials called CESAR and EOLIA trial. The CESAR trial showed survival benefit when patients were transferred to ECMO centers, though not all required ECMO. And then the EOLIA trial, which demonstrated a non-significant mortality trend with greatest benefit seen in patients with refractory respiratory acidosis. ECMO enables the lung rest by reducing the driving pressure, plateau pressure, mechanical power, potentially reducing the ventilator-induced lung injury. So coming on to ventilatory management conclusion, lung protective ventilation, prone positioning, optimal PEEP. When we come to non-ventilatory management, steroids, inhaled nitric oxide, prostacyclins, surfactants still had shown no mortality benefit. So overall, conservative fluid management, maintaining a driving pressure of less than 15, mechanical power reduction, neuromuscular blockade, individualized PEEP titration, low tidal volume, and prone positioning. SO's need of glucocorticoids and VV ECMO is the guideline for management of severe ARDS, which could improve the mortality.